next we have Dr. Abhipsa, who will be talking on secondary pituitary adenoma coexisting with central serous choroidoretinopathy, an unusual presentation.
So good afternoon everyone. I'm Dr. Abhipsa and the title of my presentation is How to Track a Snowman. So the case that I'm going to discuss, it presented in the retina OPD. The case was a 51-year-old male who had a gradual diminution of vision in the right eye from 1 year. There was no history of any trauma to the head or the eye or any headache, fever or seizure disorder. Although the past history, he had a history of hypertension and hypercholesterolemia since the past 1 year. The right eye, the vision was hand movements, and there was a grade 3 RAPD, and the left eye had a visual acuity of 20/80. Coming to the fundus examination, we can see that the media is clear in both the eyes. There was almost a total optic atrophy in the right eye and a temporal disc pallor in the left eye. And as we can see here, as marked in the box, there are RPE pigmentary changes at the fovea, and also temporal to the fovea. You can see that there is a patch of hyper and hypopigmentation which is present. And similarly, in the left eye also, there were RPE pigmentary changes at the macula. And also here we can see, as is marked by the red arrows inferiorly, there is a tract, a hypopigmented tract, which is going down from the disc towards the inferior periphery. This is the gravitational tract which I am talking about, and the arrows which are shown in the superotemporal areas in both eyes, they show small areas of NSDs. So this is the autofluorescence picture of the patient, which is showing the gravitational tracts. On doing the ocular coherence tomography through the macula, we saw that there is a disorganization of the outer layers, and there is also presence of a thicker choroid from the normal, from what we find in a normal CSCR. In a patient who has a chronic CSCR, the choroid was a little bit thicker than what we find in such cases. So in this case, we made a provisional diagnosis of both eye optic atrophy with chronic central serous chorioretinopathy, and the retina department, they sent us for a consult for the optic atrophy in both the eyes. So in this case, reiterating all the points, there was an asymmetric gradual vision loss, and there was a marked vision loss in the right eye. There was an asymmetric pallor and a chronic central serous chorioretinopathy. Also, we should not forget that the patient had hypertension and hypercholesterolemia. So these two things can be coexisting differently, and they could have a separate etiology. So the optic atrophy could have been possible because of an ischemic optic neuropathy or due to a cellular mass. Or if we add all the points together, we can think that there is a secretory pituitary tumor which is causing the optic atrophy and also causing increased ACTH levels, which is leading to increased cortisol levels and causing the optic atrophy and causing the CSCR with the optic atrophy. So we went ahead and we did the Humphrey visual fields, and we found that in the left eye there was a temporal hemianopic field effect, which was respecting the vertical meridian, and because of low vision in the right eye, we could not perform the visual fields. So this appears like, the analogy is like a junctional scotoma, which is basically caused by a tumor which presses on the junction of the optic nerve with the optic chiasm, which causes affection of the von Willebrand's knee. So we went ahead and we did the MRI brain with contrast that we had cellular mass as one of the differentials. So we found that there was we found a mass which was iso-intense to the gray matter in the axial scans, as you can see, and there was a homogeneous post-contrast enhancement, and the shape was like a figure of 8 or a snowman appearance. And these and the mass, as you can see on the T1 sagittal images, it was separate from the pituitary. It was not separate from the pituitary. So these characteristics are basically of a pituitary macroadenoma, which we find on the MRI. So our final diagnosis was both high optic atrophy with chronic central serous chorioretinopathy and a pituitary macroadenoma, and the patient was referred to the neurosurgeon for further treatment. However, the preoperative endocrine assessment of the patient was not done in this case. But we do have signs of CSC in this patient, and there might be signs which say that this CSC is steroid induced and not due to any other cause, because steroid induced CSC is atypical and bilateral, and it has a lesser male predilection, and the signs could be a chronic CSC or diffuse retinal pigmentary epitheliopathy, or a bullous CSC, or SRF with fibrin or subretinal fibrosis. And also we had a thicker choroid in our case, which is normally not present in cases of chronic CSC. So in this case, the possible mechanism is an aldosteroid or mineralocorticoid receptor pathway, which increases the choroidal vascular dilatation, and there is a thickening and leakage of the choroidal vessels, which leads to the accumulation of SRF. So in our case, we had an atypical presentation. It was bilateral, the choroid was thick, and there was optic atrophy, which was compressive due to the pituitary macroadenoma. So in this case, we were thinking that the patient has a secretory adenoma, which is causing an increase in ACTH, leading to increase in cortisol levels. We had a similar case who also had optic atrophy and bitemporal hemianopia.
Abhipsa, please conclude.
Yeah, sure. So what was common is that there was bilateral optic atrophy and a Seller type of field effect in CSC. So in this case, we hypothesized that there was a secretory pituitary adenoma, which was ACTH secreting and causing the CSC. So the take clinic message is that in patients with chronic or recurrent CSC, it is prudent to check for Cushingoid features and obtain serum cortisol levels to exclude hypercortisolism. And in cases of CSC with optic atrophy, it is advisable to do visual field testing. And not all CSC is idiopathic, and steroid-induced CSC does show different features, like a lesser male predilection, has atypical presentation, and may present with bilateral bullous variants. Thank you.
Thank you, Abhipsa. A very interesting case, and definitely lends itself to the concept that you must search and try and explain all possible findings that you have. So a couple of pressures were normal, didn't have any intraocular pressure elevation.
The only thing which was in favor of a high cortisol was hypertension, which was happening since the past 1 year in this patient, and patient was on medication for the same.
Uncontrolled hypertension. So hypertension doesn't get controlled despite
easily
until and unless we explore, and this is probably the primary cause.
Absolutely.
In fact, the second case, definitely it was checked. This case, despite telling the physician, neurosurgeon, it was not checked.
Thank you, Abhipsa. I think